speaker series, which we have most every Wednesday throughout the academic year and much of the summer. This year, as many of you know, one of our speaker series themes is Pathways Towards Universal Health Care. And of course, there are lots of ways of achieving that end. We're going to hear about many of them, both at a state level and certainly at a national level in terms of the presidential campaign that's upcoming. But no matter what pathway is chosen, it won't be successful unless there is an adequate health care workforce to provide the care that newly insured people will actually need. And so that's why we're delighted to have today Janet Kaufman from University of California, San Francisco to address this topic. Janet is a longtime friend of UCCS. She serves on the faculty council. She obtained her PhD in health policy and health services from University of California, Berkeley. She's currently a professor on the faculty at the Institute for Health Policy Studies at UCSF and also works with the Health Force Center as well as the Department of Family and Community Medicine. And she's co-director of an innovative new program that a master's program in health policy and law co-sponsored between UCSF and UC Hastings. So in any case, we're most delighted to have you, Dr. Kaufman. Thank you very much for talking to us about the impact of proposals for universal health insurance on access to health professionals.
Okay, thank you, Dr. Kravitz. It's a pleasure to be here with you and with your team. Thank you so much for inviting me. I also got to... okay, I'm sorry, we were on mute. Let's try it again. Okay, all right. So I wanted to thank Dr. Kravitz and his team for inviting me to present to you today. And yes, as we have noted, I'm going to be talking a little bit about proposals for universal insurance coverage and access to health professionals. And this is going to be the first time I'm going to give this talk. It's not going to be really sort of a research study kind of talk. It's more sort of pulling together various strands of policy, various findings from research that I've done and others have done. But I think that's appropriate on this topic because what I think we sometimes tend to do is look at some of these workforce issues in a silo and separately from the issues around access to insurance. And I really think that's unfortunate because as Dr. Kravitz said, in order for universal access to health insurance to really be meaningful for folks, to really translate into better access to care, we need to be mindful of whether we have the sufficient numbers of health professionals distributed appropriately across the state, across specialties, with the right sorts of cultural competencies so that folks can get the right care in the right place at the right time. And so what I want to do today is sort of review proposals for achieving universal coverage. And actually, before we do that, just like a review a little bit of where we are on the Affordable Care Act, and assess what these proposals might mean for health professionals, and talk about some strategies for mitigating the impact of expanding access to insurance on access to health professionals, and talk a little bit about pending budget items and pending legislation that I think is important to address these issues. So first, a little background on the Affordable Care Act, and I'm sure some of you know this well, but I think it's worth just a little bit of primer for us, particularly before we move on to talking about proposals to expand further. So again, just to remind ourselves, what was the rationale for the Affordable Care Act? Well, we have, as one of the students pointed out earlier, the most expensive health care in the world. Yet, prior to the ACA, millions of Americans were uninsured. Some are still uninsured, but a lot fewer. And we've had worse health outcomes than other developed countries across many strata. So we weren't getting good value for our money. We were spending a lot, but a lot of people still weren't covered, and our outcomes were nothing to brag about. So in 2010, the Affordable Care Act was enacted. This is not an eye test. I'm not an optometrist. But I always put this one up to remind folks just how darn complicated the Affordable Care Act is. And also say that we're only going to be talking about the left side, the insurance reform side. There's certainly a lot of health system reform. I'll talk a little, but mostly I'm going to talk about the insurance reform side. And so what was the ACA grand bargain? Well, that we would expand eligibility for Medicaid and extend the benefits of the group health insurance market to the individual insurance market, that we'd bring folks in the individual market together and covered California and other exchanges and enable them to buy coverage that looked more like employer-sponsored coverage. The other parts of in exchange for this, the ACA would establish an individual mandate and provide subsidies to encourage more people to obtain health insurance. The individual mandate maybe is as the stick, and the subsidies is the carrot to get more people to purchase coverage. And the idea was if we could get everybody, or at least almost everybody in the U.S. purchasing coverage, we'd create healthier risk pools to offset the cost of adding sicker people. Because if we remember prior to the ACA, if you had pre-existing conditions, chronic illnesses, those were the folks who in the individual market had the absolute worst time obtaining health insurance, or if they did obtain it, the price was so high that they often couldn't afford it. So that's the ACA bargain. And we've definitely had some accomplishments, with the ACA, particularly here in California. According to Kaiser Family Foundation, which is a treasure trove of state health facts, there were about 11.4 million Americans enrolled in a health insurance exchange during open enrollment for 2019. It's down a little, but still a pretty impressive number. And of those, 1.5 million were in California. We have the second largest number of folks getting coverage through an exchange of the whole U.S. The only state that has more is Florida, which didn't expand Medicaid, meaning that there's some folks in Florida who are eligible for the exchange that we'd put in Medicaid here because of the expansion. There were 15.9 million additional Medicaid enrollees as of December 2018, so that's measuring pre-ACA, pre-Medicaid expansion to December 2018. So 15.9 million additional people, a 26% increase, 4.1 million in California. We have the largest number of additional Medicaid beneficiaries in the whole nation, partly because we're the most populous state, but also we've been very aggressive about expanding Medicaid. And unlike, say, New York or Massachusetts, we weren't all that generous prior to the ACA. And so what is this ROT? Well, sort of global picture, the uninsurance rate from 2008, that's 2 years before the ACA is enacted, to 2017. 2 lines here. The purple line on top is currently uninsured. So you can think of that as the snapshot, where a question is asked, are you uninsured today? And now the answer tomorrow might be the same, or it might be different. Certainly several months from now, it might be different, because we know some of the folks who are uninsured have short spells, say, when they're between jobs. And so the light blue line you kind of want to look at is uninsured for the entire calendar year. You didn't have insurance at all. Both of those go down dramatically from 2013 to 2015 as the ACA is rolled out, and they stay down. Now this cuts off in 2017, so it remains to be seen exactly what the repeal of the individual mandate is going to do, but I would submit it's probably not going to spike back up to where it was pre-ACA. We've also seen effects of the ACA on access, utilization, and health. And there are multiple studies, and again, Kaiser Family Foundation has done some nice summaries of this. Multiple studies have found that the ACA has improved access to care, meaning, say, ability of folks to get an appointment with a primary care provider. It's increased use of beneficial services, such as recommended preventive services and services to manage chronic physical and mental conditions, things like diabetes and depression. And some evidence of improvement in health outcomes, that folks have better access, they're using services that help, and their health is improving. But certainly I think we all have to acknowledge that the ACA has some important limitations, particularly when it comes towards achieving the goal of universal coverage and universal coverage that's affordable. So some states have not expanded Medicaid. Not true of us, but definitely there are parts of the country where the benefits of Medicaid expansion are not being realized. Undocumented immigrants are not eligible for full scope Medicaid for subsidies. I mean, here in California, we have emergency Medi-Cal for undocumented immigrants, and that's good as far as it goes, but that's really only for episodes of care. It doesn't really help folks who, say, have a chronic condition and need ongoing care. So they're not eligible. Now, here in California, we've made undocumented children eligible, and that's a step farther than most states have gone, but still, that's an important limitation. The subsidies for coverage purchased through the exchange really often aren't adequate for people. People still have trouble affording coverage. And then some health plans, whether they're sold through the exchange or through your employer or whatnot, have high deductibles and high coinsurance and copayments, so that the folks may have coverage, but it's not very affordable, and those high deductibles and high coinsurance may deter them from using services they really need, or maybe filling prescriptions that really would help them. There's conflicting evidence about the impact of the ACA on access to care. I mean, I think on balance, folks have been better able to get in a provider, but there are, I think, concerns, as we'll talk about later, about the availability of health professionals, particularly in low-income urban and rural areas. It really hasn't succeeded in bending the cost curve, to use that phrase. We still are the most expensive health care in the U.S., and here in Northern California, we're particularly expensive, particularly for hospitals, I would submit, because we've had so much consolidation in the hospital side of the market that the insurers don't have the leverage they used to have in negotiating prices. So that's maybe our primer on the ACA. So let's talk a little bit about getting beyond the ACA, the proposals for universal coverage. And I mean, this could be a whole lecture, probably a whole at least week-long seminar. So this is high-level overview. So if you don't hear the details of a particular proposal that you advocate for, my apologies, but we've got to kind of keep this high level. Okay, so I think, and probably the highest level of choice, there are really kind of two approaches, or at very least there's a continuum of approaches of moving to more universal healthcare coverage. One is the incremental approach, changing things in the existing financing structure. And I'll give you some examples. And I think the incrementalist view is, you know, if it ain't broke, don't fix it. If it ain't broke, don't smash it. Fix it, twinkle it around the edges. And then the other end would be the single payer. You know, probably the most famous is Bernie Sanders' Medicare for All. We've had the Healthier California Act, but which says let's just throw this out. It's broken beyond repair. Fixing it is not an option. Let's replace it with a single payer system. So what are some examples of incremental changes? Well, probably the one that's most prominent in California right now are the proposals that Governor Newsom put forward in his budget in January. And so what are these? Well, he wants to reestablish the individual mandate in California. Now, I'm not an attorney, so I'm not going to say whether we can really make a California individual mandate stick or not, but that's certainly his goal, because I think he understands, as many do, that in order to maximize the number of people who have coverage, we've got to give some incentives. We may not want to club them with a big stick, but we do want to kind of nudge them a bit, particularly those that are younger and healthier, to buy insurance and be part of the risk pool. He's also proposing to increase Covered California subsidies for people with incomes between 250% and 400% of the federal poverty level. And if you remember, in California, folks from 138% of poverty to 400% of poverty are eligible for subsidies in the exchange. And his thinking there is those subsidies don't necessarily seem to be adequate for people to purchase coverage. He wants to establish Covered California subsidies for people between 400% and 600% of poverty. And I think that's in recognition that the way the ACA was done, you have subsidies going, as income goes up, getting smaller from 138% poverty to 400, and then fall off a cliff. If you're over 400% of poverty, out of luck. You got to pay the full cost. And I think the reality is that in a state where the cost of living is as high as it is here, that even folks over 400% of poverty may need some help in order to purchase health insurance. He's also proposing to expand eligibility for full scope Medi-Cal benefits to undocumented immigrants aged 19 to 25 years. And I think the thinking there has to do with the provisions of the ACA that lets young people up to age 26 stay on their parents' health insurance. And so part of the logic here is, well, part of the logic is, okay, well, if we're going to let, young people whose parents have insurance for them, employer-sponsored, for example, then if we're going to do that, well, then let's let our undocumented young people stay on Medi-Cal to age 26. And then probably the most radical thing he's proposed is to try to work toward a single-payer system for prescription drugs. So he's proposing that all Medi-Cal prescription drugs be a single fee-for-service program and try to have CalPERS and other state drug purchasing programs all purchase together. And the idea would be eventually perhaps we really do have single-payer pulling in privately insured folks. And so that's pretty radical. The goal of that is to try to bend the cost curve by pooling all of our Medi-Cal beneficiaries, CalPERS and others, to have more bargaining power. It's not been tried before, but it's certainly, I think, going further than we've seen anybody else go in terms of trying to deal with the cost problem. Some other examples of incremental changes. Senator Lair a few years ago, others advocate for full-scale Medi-Cal benefits for all undocumented immigrants, not just those up to age 26. A lot of talk about public option, meaning that we expand opportunities for folks to get public coverage, but yet we retain availability of privately insured folks who say can get that through their employer or really would prefer that. And so a couple examples, the State Assembly had hearings last year on universal coverage, and one of the ideas that was floated in the report that kind of summarized the findings from those hearings was enabling Medi-Cal local initiative plans. So these are Medi-Cal managed care plans that are located in California counties and really are called a local initiative because they really pull together a provider network from safety net hospitals, clinics, et cetera, in those communities to let those health plans sell coverage through Covered California. Part of the rationale for this being, we know we have some folks whose income kind of goes back and forth between that bright line at 138% of poverty, and gee, if they could stay in the same health plan, and maybe some of the time they're on Medi-Cal, some of the time it's a Covered California plan, at least they're in the same plan, they can keep the same network of providers, and if they've got chronic disease, that could actually be really good for them. At the national level, what you hear about are proposals to allow people who are younger than 65 to buy into Medicare. So that if you don't have job-based insurance and you can't afford individual insurance because you buy into the Medicare program, some of those proposals say, well, this is only for the folks who are 55 to 65. Some don't have an age limit. There's legislation pending in California right now to expand and improve insurance rate review to try to get at the cost issue by greater scrutiny from the insurance regulators. There's also legislation pending to cap the prices that hospitals are paid for out-of-network care. So those are two things aimed more at the cost curve side that are incremental. But we also have examples of single-player plans. I mentioned the Healthy California Act, and this was passed by the state Senate in 2017, but not approved by the Assembly. What it called for is a single government-run health plan for all Californians. So instead of this patchwork of Medicare, Medi-Cal, employers, Covered California, employer-sponsored insurance, CalPERS, yada, 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 single plan, much simpler. Also promised more extensive benefits than Medicare or employer-sponsored insurance typically provides. Things like vision or dental, which, yes, your employer provides vision or dental, but most of the time that's a separate policy. And most of the time, even in the UC system, your dental insurance isn't that great. So really, long-term care, much more generous for, say, long-term care than Medicare or employer-sponsored insurance. No premiums or cost sharing. So you don't pay you don't have that separate premium. You don't pay a deductible or a copay when you go to the provider. And then for paying providers, multiple payment modalities, some fee-for-service, some capitation, and we can talk a little about what that might mean. So that was the Healthy California Act. As far as I know, that hasn't been reintroduced this year. I think folks still passionate about it, but not reintroduced in the legislature. Medicare for all, there are several flavors of this, but again, Bernie Sanders' proposal is probably the most prominent. Similar to Healthy California, single government-run program, more extensive benefits, no premiums or cost sharing except maybe $200 per year for prescription drugs, which is not that much. It proposes to pay providers on a fee schedule, and so it's kind of going, like traditional Medicare, which pays providers, physicians on a fee schedule, has a DRG-based payment for hospitals, so kind of fee schedules. So, a really sort of traditional way of paying providers, which is in contrast to the way a lot of our providers are paid in California. We have we're a state, that has large medical groups, and not just Kaiser Permanente Medical Group, but others like Sutter, like Hill. And it's not uncommon for these large groups to, instead of having everything paid as a billable service, to have a capitation rate, a global budget, if you will, and manage that. And the concern, and we'll talk a little bit about why that might be. We want to pay attention to the financing system. So those are sort of just to set the stage. And so briefly to summarize on universal care, everything from some modest changes around the edges to wholesale reform. Well, why should we pay attention? Why should we matter? Why should this matter to us? What should matter, because we already face some health workforce challenges here in California. And here are several that I think are particularly important. Primary care and behavioral health workforces are poorly distributed across the state. There are issues with others, but these are the two I know best. Some primary care and behavioral health professionals do not accept Medi-Cal patients. So you may have Medi-Cal, you may have a Medi-Cal card, you may have coverage, but you may still have more trouble finding a provider than folks who have employer-sponsored insurance or Medicare. Many primary care and behavioral health professionals are at or near retirement age, so this matters when we think on out into the future. And our forecast suggests that there are insufficient numbers of primary care and behavioral health professionals who are going to enter the workforce to replace those who retire. And so I'm going to walk you through a few slides to kind of lay out this case. And so this is to look at supplies of primary care MDs per 100,000 population. And just the reason that we scale this as a ratio is that we know the population of different parts of the state varies. I mean, Los Angeles is just big. There are more people, more of everything in Los Angeles. More people, more Starbucks, more gas stations, whatever. LA is huge. You go to the northern, what we call the Northern and Sierra, what some folks know as the state of Jefferson, that vast area north of Sacramento has much fewer people than LA. And so if you just count numbers, well, LA is always number one because it has more of everything. What we really want to know is, let's put this on a scale. If we make it a ratio per 100,000 population, then we can make more meaningful comparisons. And so we see here that in California, we have about 57 patient care, primary care MDs per population per capita statewide. Okay, patient care, meaning these are physicians who say that they spend at least about 20 hours a week providing patient care. So we're not looking at managed care executives. We're not looking at physician scientists who work for Genentech. We're not really looking for my academic colleagues who maybe are in clinic half a day a week. These are really the folks whose major professional work is patient care. And the way we're defining primary care MDs here is family medicine, general pediatrics, general internal medicine, general practice. Those are the classic primary care specialties. And so we see that in the state, our ratios range pretty widely from 75 per 100,000 in the greater Bay Area to 39 per 100,000 in the Inland Empire. And Inland Empire would be San Bernardino, Riverside. So really wide variance, and then that Northern Sierra state of Jefferson, Inland Empire, and then San Joaquin Valley are the ones that struggle the most. And this is availability for everybody. We see some similar variation across behavioral health professionals, and I'll just highlight two professions here. If we look at psychiatrists, our ratio per 100,000 population ranges from 25 in the Bay Area to 7 in the San Joaquin Valley. Psychologists, Bay Area on top again, but Inland Empire the lowest, and on many of these, LA actually in the, somewhere near the middle when we put it on a per capita scale. But again, remember, these are ratios to population. Well, okay, yeah, then I'll come back. But when we look at, not go beyond ratios to population and ask the question about access for folks with particular types of insurance, things get a little more challenging. And so this is work that I actually presented here several years ago from a survey that we did with the medical board on physician participation in different types of health insurance. And here we see over on the left, all physicians, about 87% say they accept any patients with private insurance. Now, you might think that would be 100%, but we've got some folks who say work in the corrections system and work in the VA, work in the military, who wouldn't necessarily accept patients with private insurance. 74% accept Medicare, 64% accept Medi-Cal, 55% uninsured. A little bit of variance when you break it up into primary care and non-primary care physicians, but the rank order doesn't. I mean, the point estimates change a little. The rank order is the same. So that folks in Medicaid, Medi-Cal, even in those areas like the Bay Area where we have abundant supplies of primary care providers and other providers, can still be challenged. I'll go back to this one. The point of this graph is to say that when we drill down below the regions, because remember, particularly if we're thinking about Jefferson, this big, huge region. If you're in Humboldt County, having a primary care doctor in Redding or Chico doesn't necessarily do you that much good. I mean, you're really going to get in the car to drive there, assuming you have a reliable car. So you want to drill down beyond those regions. And so these are primary health profession shortage area. This is a federal designation that counties, sub-county regions, others can apply for. And the maps of that are useful, I think, for two things. One, to show you that, the majority of the geographic area that's known as a primary care health professional shortage area is rural areas. But it's also important, again, come down to Los Angeles over here, and you'll see that there are some pockets there. Up in the part of that's the high desert there in Los Angeles, which really is more rural, but part of it is south central Los Angeles, particularly for low-income folks. And so that, even in a place like Los Angeles, which is probably adequately supplied overall, you have pockets of that county that really don't have enough primary care professionals or other types of health professionals to serve the population well. Okay, age distribution. Now we know that our population is aging. We know lots of people are reaching retirement. The baby boom generation is at or near retirement. A lot of them are at or near retirement age. And this affects health professionals. It's not as much as any other profession, and particularly affects physicians. So here I've plotted the age distribution of physicians and physician assistants and nurse practitioners. I put the physician assistants and nurse practitioners on here on a, kind of as a comparison to other professions that have some overlap in scope of practice with physicians. And so what we see that of our physicians in California today, 12% are already age 65, and that was actually 2015. So 4 years ago, 12% of them were age 65 or older. 21% were age 55 to 64, which means they're going to reach retirement age by 2025, or at least reach 65. They may not all retire at 65, but that's certainly the time that we know some people retire, and people definitely think about slowing down and working less. So that's quite a concern for physicians, also a concern for nurse practitioners, less so for physician assistants, partly because it's a newer profession, and the educational opportunities have expanded a lot, so you just have a younger group of folks there. And here I'll just say for physicians, this is all physicians. When we look at primary care, it looks worse. And when we look at psychiatry, it looks even worse than primary care. Our data from the medical board suggests that 45% of our psychiatrists in California are age 60 or older. If I'd had more time, I would have tried to line up the age groups. But that's, 45. I mean, that's almost 1 in 2, over 4 in 10. Psychologists also are an older group, The good news is maybe that social workers and folks with masters in counseling, like marriage and family therapists, more of them are at least under 60. So this is real, this aging workforce. And so therefore it's important to ask questions about what supply and demand are going to look like in the future. So I'm just going to briefly show a few graphs from some work that my colleague Joanne Spetz and I have done to forecast supplies of primary care clinicians and behavioral health clinicians. I'm not going to get into the method details unless folks want to ask questions about that. But here we did 3 scenarios for primary care clinicians, and this is primary care physicians and nurse practitioners in primary care settings and physician assistants in primary care settings. So 3 sets of assumptions about how supply is going to change, like how many of the older docs are going to retire, how many new docs are going to be produced, how much substitution of NPs and PAs for physicians, those sorts of things. And we then did a single estimate of demand based on current utilization. So saying, given what we know from the California Health Interview Survey about use of healthcare services in about 2015, here's what we think demand is going to be. So notice that's based on 2015, not taking into account any of these proposals for universal access. So we think we're going to need about 42,000. If our high projections of supply are right, we're fine. If our low or middle supply projections are correct, we may have a problem unless we act now to avoid it. Similarly here with psychiatrists, we did 1 supply scenario for psychiatrists and then 2 utilization scenarios. We did the second one on unmet need because I think there's really good evidence that there are a lot of folks out there with mental health, other behavioral health needs who don't get care. Certainly folks struggle in primary care, but there's more unmet need in the behavioral health space. So really big challenge for psychiatrists there. This is a combined forecast for clinical psychologists, licensed marriage and family therapists, licensed professional clinical counselors, and licensed social workers. We put them together because there's a lot of overlap in their scope of practice. I mean, you could argue we should have separated them, but this is what we did. And there too, you see, some concerns about shortages. Maybe under the current utilization, a little less of a crisis, but still concerns that we do need to act. That left to its own devices, the labor market seems unlikely to produce enough primary care and behavioral health clinicians to meet needs. And so, what are some additional challenges associated with the expansion proposals? Well, I think increases in demand, particularly if there are no premiums or cost sharing. There's a large body of literature that compares people who are uninsured to people with health insurance, and not just employer-sponsored, also compares Medicaid, that says that people with health insurance use more services than people who are uninsured, particularly primary care services. And why is that? Well, if you're uninsured, you may be holding up and waiting, avoiding going to the doctor unless it's absolutely necessary. I mean, now if you fall and break your leg, you kind of have to. You get abdominal pain that's so severe that you're doubled over, you can't go to work, you go. But if a doctor tells you, well, your blood pressure's a little high, your diet, I'm not liking your blood sugar, you might not go get those services. And cancer screening tests, well, do I really need that? And so what we find is when people have health insurance, they tend to do more investment in the preventive primary care disease management services. And the increase in utilization will depend on the size of deductibles, coinsurance, and copayments. I mean, going back to the 80s, there's a very famous study, the experiment. There have been some sense, but that was the largest randomized controlled trial. And what that basically found is that cost sharing matters. That the amount that folks who had health plans in this experiment that had no deductibles, almost no copays, used more services than folks who faced high deductibles and copays. And the folks that weren't terribly good at discriminating between the services they really needed and the services they didn't. And this is not to say that we should be, that high deductibles are a good thing. I actually don't think high deductibles are. But I do think that the literature always tell us that there may be some value to at least some co-payments at the point of care, maybe be a little thoughtful, and particularly to think about what are the beneficial services that we don't want people to have cost sharing for. And we think about this plays out in the ACA with preventive services. There's some things you don't pay a co-payment for because the folks who drafted the ACA said, well, we want to get, we know colon cancer screening is effective. We know cervical cancer screening is effective. We don't want cost to be a barrier there. But for other things, we do maybe want folks to think a little bit and pay some of the cost. So that I think is important. And this is just some evidence to why that might matter. This is data from the California Health Interview Survey from 2017, looking at number of physician visits by insurance type. And I think the key takeaway here is we look at folks who are employer-sponsored insurance, only about 14% had no visit. You know, it was 86% visited the doctor at least once in the past year. For folks with Medi-Cal, it was about 92%. But for folks who were uninsured, only about 58% visited the doctor at least once. 41.8%, 42% no visits to the doctor. Now, some of them are younger, healthy people, and maybe that's okay. But I think the evidence would suggest that some of those folks might really have benefited at least from some care. So it's just important to note that when we move folks from uninsured to insured, they're more likely to use services. And it's not to say that using services is bad, but that it does mean we need to think about, do we have adequate numbers of health professionals, adequate numbers of health facilities to meet their needs? Payment rates are also going to be important, as well as how people are paid. And so a long set of studies looking at and comparing across physician participation in Medicaid across states tells us that physicians are more likely to participate in Medicaid in states that pay higher rate. In 2016, we had the third lowest Medicaid fee-for-service rate for physicians of any state. And certainly for among the states that are in better shape economically, we're we're scraping the bottom of the barrel. Now, in fairness, as the DHCS folks will point out, a lot of our Medi-Cal folks are enrolled in managed care, and physicians are not necessarily strictly, or certainly medical groups are not strictly paid by fee-for-service. But we don't know a lot about what they actually are paid. We do know historically those fee-for-service rates are lower than rates paid for Medicare and commercial insurers. So I think in terms of our physicians going to participate in any insurance coverage, if we did move towards something like single payer, a lot is going to depend on payment rates. Type of payments matters too. Fee-for-service, you get more, you're paid more when you do more. And so there is an incentive, not to say that our physicians are not thoughtful and thinking about their patients. Absolutely they are, but there is also that financial incentive to do more because you're going to be paid for more. And that's definitely distinct from a global budgeting model. We say, okay, here's your budget for what Kaiser's model, here's your budget for a defined population. Figure out how to manage that budget as effectively as possible. And so you see Kaiser doing things like saying, well, maybe everybody doesn't need to come in for a physician visit for every refill of every medication. Maybe we can do some of this by looking at the patient's record. Maybe we can do some video visits or some email visits. Maybe there are ways of doing this more efficiently. And again, not to say that capitation is perfect. We had a long legacy in the state in the 1990s of health plans under capitation probably being more restrictive than really was fair and appropriate. And some folks not getting services they needed. I would say we've made a lot of progress, particularly with the establishment of Department of Managed Health Care, independent medical review, other procedures. I think that while never perfect, we are better at ensuring that folks get what they need. But still, I think really important to think about how are folks going to be paid. Okay? So some strategies for mitigating the impact of expanding access to health insurance, and I'll try to buzz through this quickly because I know we need to get to questions. First, I just want to read a quote, and this is from Andy Beinman, Marian Mulkey, and Rick Cronick, and they were the consultants who were retained by the Assembly Health Committee and I think financed by California Healthcare Foundation to work with the Assembly Health Committee on the hearings that took place in 2017, 2018. That's a really wonderful project. I mean, I urge you, if you want to educate yourself on the topics, reading their report, listening to some of those hearings. And so this is Dr. Beinman and Dr. Cronick and Ms. Mulkey actually paraphrasing some stuff that I said at a hearing. So it's like kind of weirdly flattering to have your colleagues regurgitate what you said and say, you said it better than I did. So anyway, here's the summary. To overcome workforce shortages, California needs a comprehensive strategy utilizing incentives to overcome the market forces that discourage physicians and other clinicians from specializing in primary care and practicing in underserved areas. So what might that mean? Well, a little more visual representation, and this comes from a report that I and colleagues did for Kaiser Permanente Foundation, and sort of things in 4 areas, but I'm not going to talk so much about the data, even though I'm a data nerd. I think for your purposes, more important is enhancing the education pipeline, recruiting and retaining clinicians, and maximizing the existing workforce. So enhancing the education pipeline, meaning expanding training and increasing recruitment and retention of folks who are more likely to practice in underserved areas, underserved populations. So people from rural areas, people from urban, Latino, African American, Southeast Asian communities, people who speak languages other than English, and preparing folks to really care for underserved populations. Then recruitment and retention of clinicians. How do we create incentives for primary care and behavioral health clinicians and others to go where they're most needed? In this report, we talked a lot about loan repayment programs. Physicians for Healthy California with Proposition 56 money has just announced a really big loan repayment program. There are others. Other incentive programs. Some states have programs that are about giving folks incentives to establish a practice in a rural community. And in fact, Physicians for Healthy California is going to do that for dentists. Practice support, meaning things that can help folks. Rural primary care practice can be pretty darn isolating. And so there are a number of efforts to use telehealth technologies, other technologies to really help make those practices more viable. We also want to maximize the existing workforce, and that can be reforming the delivery system. Certainly it can be practice regulation. We had a nice conversation with the students earlier about legislation introduced by Assemblymember Wood that would allow nurse practitioners in California to practice without physician supervision. That would actually bring us in line with most of the states in the western part of the US and is consistent with literature that shows pretty convincingly that nurse practitioners and primary care physicians provide equivalent quality of care, and also shows that when you have nurse practitioners practicing more independently, you tend to have better access to care. Particularly, they're more likely to end up in those underserved areas where we most need folks. Certainly technology, telehealth can be used to support clinicians, but it can also be used to support patients. And again, there's legislation pending this year to expand reimbursement for telehealth. Payment reform, really thinking how do we pay providers in a way that incentivizes them to step back and say, well, let's not just reflexively do more, let's really think about what people need. And if they do need more, what is the more that's best for them? Maybe it is a nursing home for some folks. For other folks, it might be home health. For some folks, maybe more is more intense. Maybe what they want is more intensive chemotherapy, radiation for the cancer. Or maybe for some folks, what they want is a palliative care model that says, okay, let's focus on living as much as we can today and not necessarily be all that aggressive with treatment. So just a few quick items. State budget items this year. Song Brown program is for primary care residency training. Prop 56 is also for residency training. So these are 2 items. I think really we can say that the governor and others have been really supportive of expanding residency training in primary care. A little less so in behavioral health, but certainly in primary care. Big investment in loan repayment programs over the next 5 years, and $50 million for mental health workforce. So I think we want to stay tuned to see what's in the May revise and what comes out in the budget from the state legislature. Legislation, I mentioned the scope of practice. There's a couple of bills for expanding medical schools in the San Joaquin Valley and at UC Riverside, 2 of the areas of the state that have the greatest need for additional primary care and behavioral health professionals. AB 871 is also about residency training. AB 476 calls for the Department of Consumer Affairs to look at how we go about licensing foreign-trained health professionals. We have a number of folks in the state who trained as a health professional in another country, and some of them do go on and then become licensed here, but some don't. And is there more that we could do to leverage that workforce, and particularly in our immigrant communities where these folks, if they're coming from the same countries as recent immigrants, speak the language, understand the culture, may be able to provide better care than others. Want to just briefly mention the California Future Health Workforce Commission. I had the pleasure of serving on the staff of this. This was about an 18-month effort from the summer of 2017 through February 2019, released its report that addresses many of these same topics. So conclusion, proposals for expanding access to health insurance have implications for access to health professionals. Expanding eligibility and decreasing cost sharing likely to increase utilization. Probably a good thing overall, but something we need to pay attention to if we want to be sure that we're have adequate supply. And then adequacy of payment rates and type of payment rates are also going to be key. And I hope I've convinced you that when we work towards the goal of expanding access to getting toward universal coverage, I've also convinced you that we need to make some parallel investments in the healthcare workforce to ensure that access to better access to insurance translates into better access to care.
Right. Thanks very much. We can now take questions. Please